Everyone.
All right, happy May Day. It is May 1st, and this is the Senate Health and Welfare Committee. We're looking at several bills, hopefully getting to some closure on some of them, at least ready to vote. So that's our goal. And then we'll be spending a little bit of time on H91, where we're still a ways away from the vote, still marking up. So we're going to start with 482, but I know that there's someone in the room who has a birthday today, and we're just going to say happy birthday without any names, but happy birthday. We wish you well.
No poems,
Huh?
no poems, no haikus.
Well, we can think about
No
that.
limericks?
We will think about
Oh,
it. That's a good idea. This one might have
Let's do a
some.
limerick.
Yeah. Okay. So we are on 482. And Owen Foster's going to come down at 9:30, a little out of sync with the order of our day, but we'll hear his thoughts when he gets here. But we do you want to, Jen, would it be, I know that there are people in the room who are interested in both 482 and 266. I'm not sure anyone additional is coming in on 266. I'm thinking we might reverse order. And then if we have to, we'll go back. So Jen, why don't we look at 266? I'm looking at
People have proposals?
Sam might have, there is a language from
I can have my
Healthcare Advocate and
others.
Voss. You want to present something to us?
I think Mike wanted to come down, so let me just text him, but if you want to.
I'm happy to start off.
Sure, let's do that.
Okay.
I know it's hard to be in two places at once, and I appreciate that both the House and the Senate committees on health care are working on similar topics. Need attention.
Sorry, let me just.
Sure.
Mike is on his way.
Perfect.
Okay. Devin Green, Vermont Association of Hospitals and Health Systems, and thanks for having me in and working on this bill. I do appreciate the healthcare advocates working with us on trying to get the reporting in the right place. And really appreciate their patience also, because this is very technical and I was trying to wrangle a number of people to get their feedback. And so just really appreciate their work on this. Essentially, we have a couple changes that we're making to H266. The biggest one is, so they're sort of technical. The biggest one is on the sort of meat of the reporting and getting to the amount that is collected per 340B. And so we have laid out a process to do that. As you heard from Don Cogger from Gifford, it's really difficult to do this in bundled payments.
Yeah.
So what we are saying is do a estimate based on the WAC, which I'm forgetting what that stands for now. Wholesale acquisition costs. Thank you. And so, trying to ballpark it off of that so that we have a more accurate number. Originally, we had the group purchasing number. We are going to work with this number. There still may be hiccups that come up with this. I would say that for this first year, it's not going to be a science. We may need to come back and adjust it, but I think this is a good starting place. And so we will start using it. And then the other piece is the reporting on third-party administrators. Our folks were concerned about having a chilling effect around vendors working with us if this was publicly reported. So we are asking that information be confidential, and the healthcare advocate would have access to that information. But again, we just would like it to be confidential and just have the folks who, the Green Mountain Care Board and the healthcare advocate with access to that information.
Okay, that's good.
And
Savings.
am I, oh.
A, B, and C.
There's a piece where we had this debate, the semantic debate about revenue versus savings.
Uh-huh.
My folks say savings, Green Mountain Care Board and healthcare advocate say revenue. I'm gonna go, as I'm an English major, this kills me, but I'm gonna go with the revenue for now. We'll see if we come back and we want to change it later, but this is where it's landed.
All right, when we look at the language, this will all become clear, but
Yes.
it's helpful to know that you have come to some agreement on some of the more controversial parts bill. Thank you for that.
Thank you.
And so we'll ask the healthcare advocate to come up. Maybe there's a place between revenue and savings. English.
No.
Everything the hospital association said was correct.
My shortest testimony.
And you did send
Might differ,
some,
I think.
maybe introduce yourself.
Yeah, so we sent the language and it was good to work with the hospital association. I think we found a good compromise to get just on a high level to get in the areas where we can get actual numbers, we get actual numbers. In the areas where it's difficult to get actual numbers because of the bundle payments that we get in estimation. And so I think that's the meat of it. And then we think that this is really important for us to be able to see the flow of these dollars, just so that we understand them.
Transparency is a big part
It's
of
great.
understanding and moving forward.
It's really transparent. So Ledge Council has the language and, there was maybe another section that we agreed didn't make sense. And so we agreed to cut it, given that,
Okay.
given the other changes. And so,
Well, we're gonna have Jen come up and we'll look at what you're presenting to us. Senator Gould.
Just wondering, while we're maybe transitioning, we could hear from the FQHCs if this is gonna be a good landing place for this.
this is only reporting for hospitals.
This is only hospital
All
reporting.
right. So then, good. Thanks.
So that's section 2 in the bill.
Everything else.
Yeah.
Thank you.
So we're gonna go to Ledge Council. Thank you very much for your work on this.
Good morning, Ben Hardy from the Office of Legislative Counsel. I don't have a markup version for you to look at because
No,
I only
no,
jumped on this and you haven't discussed it yet.
no. We got it.
Um,
There might be some massaging.
so I'm happy to put the bill up, but I'm not sure what you would like to do next.
Do you have the language that the healthcare advocate sent?
I have their suggestions and then I need to be reminded where the confidentiality piece goes. Is that in the vendor list? Okay.
So maybe we could walk through the bill, and stop a little more time on section 2 and see where this might fit. And then we might we'll see where we are and ask for a copy.
So we are looking at H266, an act relating to the 340B prescription drug pricing program. Section 1 is the new subchapter in 18 VSA chapter 91, which is the chapter on prescription drug cost containment. This is a subchapter on the 340B drug pricing program. Starts off with definitions that we've looked at before. Now we're still looking at the Pass by House version, so no changes. The definitions of 340B contract pharmacy, 340B covered entity, 340B drug, discount, manufacturer, pharmacy benefit manager, and rebate. I'm happy to go through any of the definitions, but I don't know that you need to at this point. 4682 is the language prohibiting a manufacturer or its agent from denying, restricting, prohibiting, or otherwise interfering with, directly or indirectly, the acquisition of a 340B drug by or delivery to a 340B contract pharmacy on behalf of a 340B covered entity, unless receipt by the 340B contract entity is prohibited by the U.S. Department of Health and Human Services.
Your pharmacy. Okay.
So it's on behalf of an entity.
Oh.
The entity contracts with the pharmacy.
Got it.
Subsection B, a manufacturer or its agents shall not directly or indirectly require a 340B covered entity to submit any claims, utilization, encounter, purchase, or other data as a condition for allowing the acquisition of a 340B drug by or delivery of a 340B drug to a 340B contract pharmacy, again, unless the claims or utilization data sharing are required by the U.S. Department of Health and Human Services. Also prohibits a manufacturer or its agent from interfering with the ability of a pharmacy contracted with a 340B covered entity to dispense 340B drugs to eligible patients of the 340B covered entity. And it requires the manufacturer agent to offer or otherwise make available the 340B drug pricing to the contract covered entity or contract pharmacy in the form of a discount at the time of purchase and not as a rebate. Sort of recoup later. Nothing in this subchapter applies to Medicaid. Violations, a 340B covered entity, contract pharmacy, or other person who is injured by a manufacturer's or agent's violation of this subchapter can bring an action in Superior Court for injunctive relief, compensatory and punitive damages, costs and reasonable attorney's fees, and other appropriate relief. And a violation occurs each time a prohibited act is committed. Prohibited act is each package of 340B drugs subject to a discriminatory action by a manufacturer or its agent. Finally, nothing in this subchapter should be construed or applied to conflict with or be less restrictive than federal law for a person regulated by this subject. That's section 1, and I don't think you've heard any changes proposed to that. Section 2 is the part that you just heard from the hospitals and the healthcare advocate. So reporting on participation in the 340B drug pricing program. And this is a new section that would be added in Title 18, a different part of Title 18 in the big chapter we spent a lot of time in on healthcare administration. This would require annually on or before January 31st, each hospital participating in the federal 340B drug program must submit to the Green Mountain Care Board a report detailing the hospital's participation in the program during the previous fiscal year, and that report will be posted on the Green Mountain Care Board's website. So I think, thank you. First proposed change, if you want me to try to point you to some of those proposed changes as we go
Yes,
through.
it would be helpful just to know where it might fit.
Yep, so on this introductory paragraph here, the hospitals would be submitting to the board in a form and manner prescribed by the board, a report detailing their participation, basically letting the board tell the hospitals what information and in what format they want that information to report. All right, so the report is posted on the Green Mountain Care Board's website and must contain at least the following information. And so they are proposing to change, to swap out subdivision 1, I believe, with a new subdivision 1. So in the language in the bill, it's the annual estimated savings to the hospital from participating in the 340B program, comparing the acquisition price of drugs under 340B to group purchasing organization pricing. So you can hear already there's some language that Devin was talking about changing, and Mike as well. So savings, when it's referred to, will become revenue. Group purchasing organization pricing would not be included, and instead they have a number of different types of reporting that they are proposing. So there would be aggregated acquisition cost for all prescription drugs and the aggregated payment amount the hospital received for all of those drugs broken down by specific distribution channels. dispense drugs from the in-house pharmacy, dispense drugs from a contract pharmacy, administer drugs paid separately, and administer drugs paid by bundled payments. And it would require the hospitals to estimate payments from administered drugs for which payment is bundled with payment for other services by comparing the acquisition cost for the drugs to the wholesale acquisition cost for the drugs. That's the WAC.
So different.
So yes, completely different. So
Very,
the proposal would be to take out existing subdivision one, put in a new subdivision one. That's the most sort of wholesale change. Subdivision two, the aggregated amount that the hospital, aggregated payment amount that the hospital made to pharmacies with which the hospital contracted to dispense drugs with patients under the 340B drug program. So how much did they pay contract pharmacies during the previous hospital fiscal year? Number three, is the aggregated amount the hospital made to any other outside vendor for managing, administering, or facilitating any aspect of the hospital's 340B drug program during the previous hospital fiscal year. And then the proposal is to add, followed by a list of the vendors by name and a brief description of the work performed by each vendor with some confidentiality language added on. Then they are proposing to just strike out the number 4, I believe. So the number of claims for all prescription drugs the hospital obtained through 340B drug program during the previous hospital fiscal year. And I think some of that may be captured in what you're getting in the revised number 1. Is that the rationale?
Yeah.
Number 5 is a description of the ways in which the hospital uses, and this would change throughout, savings to revenue. So uses revenue from its participation in the 340B program to benefit its community through programs and services funded in whole or in part by revenue from the 340B program, including services that can support community access to care that the hospital could not continue without that revenue. It's revenue. And then finally, a description of the hospital's internal review and oversight of its participation in the 340B program in compliance with federal program rules and guidance. The reporting provisions would be repealed on January 1st, 2031. So not an indefinite annual report. And section 4 has the effective date. The act would take effect on passage with the first hospital reports on drugs due by January 31st of 2026.
okay, so there are significant changes within the reporting section. It sounds like we probably should look at the language.
Yes, because I'm
Yeah.
gonna, you're gonna need to put it into context here.
So there's no value placed on the word revenue. It's simply a number. It could be savings or it could be revenue. And the point is that it's going to support patients. That's key, I think, for some people. If it were going for a golden parachute, we might not think, we might think of it differently. All right. So can we look at this language? When do you think we can look at this?
Tomorrow, when do you want to look at it?
Oh, okay.
Tomorrow, next week? I don't know when you want to look at it. I don't.
Yeah,
really
well,
know
if you have it,
today, because I will be
if you, I don't know.
in the witness seat for the next
Yeah,
2.5 hours of time.
we are only looking at H91 tomorrow, so if there's some time, you could come in, maybe, based on whatever your schedule is, we
Yep.
can pick it up.
You should be able to make that.
For half an hour.
Yeah, actually, at the moment, there's nothing on my calendar for tomorrow, so you pick your time. I
You
haven't gotten that far in healthcare, so.
Let's do it early. Let's do it at 9 o'clock. We'll do it at 9 o'clock.
Great.
And then, we'll start with H91 after that at 9:30.
So what probably just from a process standpoint, what I'll plan to do is try to put some of this language together later today and send it to the
Right,
parties who've worked on it to make sure I'm capturing
okay,
what was intended. And then bring it in.
perfect. Thank you for that. Okay, so take care of that. Bill, we're on to 482. I think that Chair Foster will be down in 5 minutes. So committee, Nancy Kane, who was in the other day with testimony, did send her testimony in writing. She also sent an article, on how hospital ratings are developed, financial ratings are developed, through the Fitch system. And both of those are posted on the webpage for you. She did get a little, there is some greater clarity in she said, from her testimony. So we probably should look at that. And she has volunteered to come back should we need that. So she can offer clarity on that. She's posted what we have posted. So go through that and then we can make a decision about how and when and if you'd like for her to offer her suggestions further. So what I'm going to do at this point is just take a quick break and then when Owen Foster comes in, we'll hear his response to the questions that were asked. I also shared with him the information that Nancy Kane sent, because it does, the Fitch report, as well as what Nancy indicated on how cash on hand affects decision-making and other options for decision-making. She did offer clarity on that. So I sent it to the Green Mountain Care Board as well. Because we are post the initial emergency. And so there might be some suggestions for improving the emergency response. So it's not that we are going to not have an emergency response, but it's the information that's considered in the process by the board, by the hospitals, by insurers. So we're not trying to say we're not doing this, but we want to make sure that we're getting the best information that we have that's out there. And Nancy seems to have some of that information. So quick break, and when